Well, thank you very much for the invitation. It's a pleasure to be here, and I wish I had a more pleasant topic to talk about. But my work is on the International Monetary Fund and health systems, and I will talk about how it intersects with the Ebola crisis. And in that way, I will feed into some of the themes that the ILO Director General mentioned this morning. So what we know, and what I don't have to talk about at length, is that weak health systems are a central impediment for improving health status of populations around the world. And indeed, we know that West African countries have lagged behind most other regions in terms of health system development. So attempts to explain progress or lack of progress in these countries has really highlighted the role of international organizations or non-governmental organizations in these countries' health systems. And I will focus on one specific international organization, the International Monetary Fund, which should be known to most here, if not by participating in demonstrations against it, as trade unions have done around the world. And what the IMF is known for is so-called conditionality. So the organization gives loans to countries in exchange for policy reforms on issues like austerity, labor market deregulation, privatizations, or liberalization of trade, and so on. So that's really what the IMF is known for. That's what its reputation is. But if we look at what its managing director, Christine Lagarde, recently said, she said structural adjustments, that was before my time. I have no idea what it is. We don't do that anymore. Seriously, you have to realize that we have changed the way in which we provide our financial support. It's really on the basis of partnership. And indeed, if we look at the recent rhetoric coming out of the IMF, one would be excused to think that this is this very nice, friendly institution that cares a lot about social protection, cares about inequality. The ILO Director General just said that they publish studies showing that inequality hurts the economy after a point. And if we look at what they've said on the Ebola crisis, then they've really tried to put themselves at the forefront of dealing with the crisis by committing more money for aid. Christine Lagarde said back in October 2014, said it's good to increase the budget deficit if it is to cure people and fight the disease, and so on. So together with colleagues, we asked a rather provocative question in a recent article, which is, could it be the case that the IMF contributed to the circumstances that enabled the Ebola crisis to arise? And to do so, before I go into the findings, let me just summarize what the debate is really about when we talk about the IMF and social protection or health policy. On the one hand, we have the IMF, who says that they help countries achieve economic growth, and they have these priority spending conditions whereby countries actually, under IMF programs, actually spend more on social protection policies than they used to. Then the critics actually say that growth never comes as a result of IMF programs, and there is a lot of collateral damage on the social sectors of these countries, and at the same time point out these inconsistencies between the rhetoric of the IMF about caring about inequality and social protection and the practice of its programs. And then there are other types of arguments, I call them agnostic arguments, who think that the two things are completely unrelated, that there is no link between what's going on, what the IMF does, and what is happening in countries' social policies. So to study these issues, I went to the IMF, that's it in the picture. I spent a month in its basement collecting documents. And the documents I collected were all of the loan agreements of all countries, basically, and the letters that governments send to the IMF. And tried to extract information out of those documents about what kind of policy reforms were introduced and whether and how these policy reforms actually affected social protection systems. I'll talk today about the 3 Ebola-stricken countries in particular, but I can talk more broadly in the Q&A. And I identified 3 pathways through which IMF programs affect social systems. The first is by shrinking fiscal space, by austerity, basically. The second is by wage and personnel caps, which has been a very controversial policy, and I'll talk more about it, and then through some other structural reforms. But before I go to that, I want to talk a little bit about conditionality, so these policy reforms. The IMF stipulates a long list of policy reforms that countries have to implement in exchange for financing. So what does that look like? What does West African policy reforms look like? I generated this graph, and I'll talk a little bit about it. So it's all 16 West African countries. And basically blank space means no IMF programs. And then the instantly clear observation is that most countries have been under the IMF for most of the time over the past 3 decades, 29 years. And indeed, when you see the dark brown, that's really tough IMF programs. Those are programs that have between 60 and 90 approximately conditions. So really as strict as possible. You see Cote d'Ivoire, for example, has had some really tough programs very recently. And the other depressing fact is that if you look at the blank space, that's also interesting because it often denotes times of war. So whenever there's a war, the IMF doesn't go in for various reasons. But when there's no war, then the IMF is in and running its structural adjustment programs. So how does this image of West Africa compare more generally? If we look at the number of conditions over the past 30 years across the world looks like this. So it doesn't show up very well in the big screens, but it's very clear that West Africa has had most conditions to implement. Together with Pakistan and Romania and Bulgaria, those have been the countries most affected. And then it's Eastern Europe, Turkey, and other parts of Africa or Latin America. So Mauritania, for example, has been under IMF programs for 25 out of the last 29 years. And they have had to implement a total of 1,058 conditions. So I will not go into that at the moment. I will move on to the Ebola-stricken countries. So the first pathway I will talk about is the shrinking of fiscal space. So the IMF imposes strict macroeconomic prescriptions, austerity. But if we believe its managing directors, they all claim that they actually pay a lot of attention to social issues. In 1996, 20 years ago, the managing director then said, Rodrigo de Rato, who is, I think, currently under criminal investigation in Spain, he said in 1996, for fraud, by the way, he said in 1996, we're strongly committed to making sure that countries have the fiscal space they need to expand social programs. And for that reason, they introduced so-called priority spending conditions. If you listen to what the IMF is saying, they always highlight these types of conditions that stipulated increases in spending in its program. So they say, well, look, we impose austerity, but at the same time, we shelter social protection policies from cuts. So I went and counted whether these conditions appeared and whether they were actually implemented. So across West Africa, I counted 255 such conditions over the last 20 years. I found implementation data for almost 200 of them, and only 87 were met. At the same time, all austerity conditions, labor market conditions, trade liberalization conditions, privatizations, whatnot, all of that was met. However, as one may have expected, the social spending conditions were never met. Indeed, one could argue that this was more a rhetorical strategy of the IMF to just chuck these conditions inside their loans, so when civil society or academics accuse them of not doing anything, they can say, well, look, we have these conditions in there. But in fact, this data shows that they do not pay enough attention to countries meeting those conditions, helping countries achieve those spending targets. And indeed, if we look at what Guinea in 2006 was writing to the IMF, they said, that is the letter of the government to the IMF at the time. They said, unfortunately, because of the reduction in spending, it was not possible to respect the targets for priority sector spending, so that is health and education. Sierra Leone as well, all targets were observed. That means all targets like austerity and privatizations were observed, except for the floor on poverty-related expenditure because of low domestic investment. And at the moment, and we could find similar quotes in Benin, Cape Verde, and Mali. Then the second pathway is wage and personnel caps. So the pathway here is that there are many public sector layoffs and limits on the government wage bill, so limits on how much governments can spend on wages, which leads to a so-called medical brain drain. Basically, health workers leave from these countries because they are not paid a living wage. So when we wrote that, Sanjeev Gupta, the Deputy Director of Fiscal Affairs at the IMF, wrote a letter to the Lancet saying that it is simply not correct to say that the IMF requires caps on the public sector wage bill. Programs have not placed limits on the wage bill during the 2000-2014 period. So while he wrote that, in the IMF archival data, in the 2006 staff report on Sierra Leone, we see the staff noting that they have the view that reining in the wage bill and improving control of wage spending needs to be urgently addressed. Indeed, Sierra Leone had several years of wage bill limits. And over those years of those wage bill limits, the country saw a collapse in the number of health sector workers. In the case of doctors in particular, in 2008, there were 0.016 doctors per 1,000 people, one of the lowest such ratios in the world. And when the country introduced its widely lauded free healthcare initiative for children, pregnant women, and mothers, the IMF wrote to the country saying that they should implement a more gradual approach towards increasing wages in the health sector. At the same time, the health sector at the time was not paying living wages, and the only way that the free healthcare initiative in the country would succeed would be by raising wages. At the same time, even now in recent years, the IMF still imposes wage limits. Just in the last 2 or 3 years, I've noted that Moldova, Cote d'Ivoire, and the Honduras all had such limits. And the third pathway that I identified had to do with budget execution. The IMF claims that they help governments meet spending targets. It is a true issue that very often low-income country governments do not meet the health spending targets they set. So they have budgetary appropriations for health, and they do not manage to reach 100% of that. And there is scope for improvement in spending there. But at the same time, what the IMF did when it comes to budget execution was to push forward with an agenda of decentralization, health system decentralization, fiscal and administrative decentralization. Now, the idea behind this is perhaps appealing in the first instance, which is that health service responsibilities move away from the top, from the government level, and go down to the local level, where the local level is supposedly more responsive to local needs and know how to respond appropriately. But in fact, what this has resulted in has been governance problems, coordination problems, and capacity problems. Indeed, when we talk about infectious disease control, as in the case of Ebola crisis, infectious disease control has to be centralized. You cannot have a decentralized infectious disease control. And indeed, even the IMF, after pushing for decentralization in Guinea in 2002, just 6 years later, in their own internal documents, they reported governance problems with decentralization and a deterioration in the quality of healthcare delivery. So how did the IMF respond to this work and these criticisms? They said basically their main response in their letter to the Lancet was that it's not correct to say that healthcare expenditures declined in these countries. And I agree with them. It's indeed not correct to say that, and nobody said that. I didn't say that, and none of the critics actually said that. But the question is, what do we mean? It's a question of twisting the words a little bit. If countries spend slightly more than they used to, especially if these are countries that spend tiny amounts of health by any comparison worldwide, then what does it mean to spend just a tiny bit more? Is that enough spending to meet the Millennium Development Goals or now the Sustainable Development Goals? Indeed, in the African Union countries, there were the Abuja Declaration about 15 years ago. And from what we know now, the most recent data from the WHO show that very, very few countries have made progress to meeting those spending targets, which are at 15% of the national budget. But at the same time, spending is important, but who spends is equally important. Is it the public sector or is it NGOs? A lot of what we know from low-income countries is that there is this process of displacement where NGOs come in and take over responsibilities that the state could and should have. And that because NGOs come in, the state actually ends up spending less on health than they used to before. So, which affects the long-term development capabilities of health systems in low-income countries. Also, what is the money spent on? That matters tremendously. Is it on community health initiatives? Is it on infectious disease control and prevention and child and maternal health? Or is it on expensive pharmaceuticals? And finally, time frames matter. We really should be talking not about healthcare spending, but healthcare investment. And healthcare investment takes time. It's not a year-to-year process, but it's a sustained process over a number of years that results in strengthening health systems. And indeed, that is the point that we're trying to make with the article, is that stuff that were happening 5 or 10 years ago still have an effect today. If a country decentralized a decade ago, that still matters today, that has an effect on what their health system looks like today. So wrapping up, the main conclusion of this work was that IMF programs contributed to underfunded, insufficiently staffed, and poorly prepared health systems with long-lasting consequences. But at the same time, what kind of my take-home message is that West Africa is not unique in its experience with the IMF. In many ways, it's the most pronounced case, but countries have had to implement such policies around the world. And indeed, if we look at the recent rhetoric of the IMF, these are 2 quotes I pulled up yesterday from their website. The first one says that policies affecting labor are peripheral to IMF programs. And the second quote was that IMF programs seek to protect social spending in a way that is both fiscally sustainable and cost effective. Now, I would argue that both these quotes are fundamentally disingenuous. And if we look at what was happening in the Ebola-stricken countries over the last 20 or 30 years, in Argentina in the early 2000s, in Greece, Portugal, and Ireland, today, the Ukraine as well, it's the same thing. It's basically the same set of policies that have been introduced over and over again. The ILO Director General noted a kind of cognitive dissonance, he said, about the IMF. I would say it's hypocrisy. I would say it's saying one thing and doing another thing. And in a way, that is what I see our role both as scholars and as civil society, to hold these organizations to account. Because the IMF is here to stay. That's very clear. They have had a huge injection of cash in 2008. They have much more money to lend than they used to. And they have increased their lending since the onset of the global financial crisis. So really more transparency and holding them to account about doing what they say, they claim they're doing, whether it's on labor issues, on inequality, on social protection, is a debate to which we can contribute, both as scholars and as civil society. Thank you very much.